Báo cáo viên kế tiếp là giáo sư Romaric Lofroy. Ông là một bác sĩ về điện quang can thiệp ở Dijon, Hàn Quốc. Ông rất là ờ, hứng thú trong những cái nghiên cứu về can thiệp trong ung thư, cũng như là can thiệp về ung thư gan, can thiệp về những cái huyết khối ở tĩnh mạch sâu và những cái bệnh lý về huyết khối động mạch. Bài báo cáo tiếp theo của ông á, là nói về một số cái mối quan tâm liên quan đến cái dung dịch nút mạch ngoại biên. Um, so I would like to introduce Professor Romaric Lofroy. He will talk about growing interest of for liquid and peripheral application. And please, are you online,
Yeah,
Professor Lofroy?
can you hear me?
Yes, we can hear
Okay,
you.
perfect. Great.
Okay.
Thank you very much. Thank you very much for your kind invitation. It's a great pleasure to be part of this online. Unfortunately, so I will make a talk about the growing interest for liquids in general and especially in peripheral applications. We use more and more liquids in our daily practice. All kinds of liquids for peripheral indications. And if we look at the last 5-10 years, it has been developed a lot by many companies, different products which can be used for different indications. And I will try to make a short overview of the different liquids we can use. Of course, in 20 minutes, it's quite short, but I will show you some examples where which are very nice indications for liquids in general. So here are my disclosures. So if we talk about liquids, we talk about three main categories of liquids: the sclerosing agents, probably the cheapest ones and the easiest ones to use, I would say. The goal is to cause inflammation and destruction, leading to intravascular coagulation, thrombosis, and fibrosis. So we have different liquids, and I will skip this because it's quite easy. But we have, you all know that by heart. The main one is alcohol, of course, which can be very challenging to use, very efficient, especially for arteriovenous malformations, and venous malformations, but very by endovascular approach, it can be very challenging to use with and very risky, I would say. So it's always a balance between the risk and the efficacy, and we have now on the market some other liquids, I would say, which are less risky. We have polydecanal, which is etoxysterol or STS, very cheap and very efficient for especially for varices, I will come back on that, and bleomycin or doxycycline. The two other categories are cyanoacrylates, so adhesive liquids. So the goal is to get an exothermic reaction. We need to use Lipidol, which is a French product coming from Gerbet, to make the glue radiopaque, because it's not, and to play with the dilution with glue according to the kind of vessel you want to embolize, if you want a proximal or distal embolization. So different cyanoacrylates on the market. The oldest one is histoacryl, at least in Europe, but in Asian countries also, because this is only glue which is available in some countries. Trufil, it's N-butyl cyanoacrylate also, which is available only in the US. And in Europe, we have Glubran 2, which is a glue with a delay of, with a polymerization time, which is already a little bit delayed as compared to histoacryl, making the glue a little bit easier to use as compared to histoacryl, for which the delay of polymerization is very fast. And we have a new one, which is Magic Glue coming from Balt, with a delay of polymerization, which is even longer, I would say. And less adhesive, so less risky in terms of entrapment of the microcatheter. And we have the last but not least, the polymers. So we need to inject DMSO, dimethyl sulfoxide, for that. We talk about precipitation as compared to cyanoacrylates, where we talk about polymerization. And so this is ethylene vinyl alcohol, so coming with tantalum to make the polymer radio-opaque. It needs to be agitated. So this is onyx, the oldest one, and the squid coming from Balt, now onyx from Medtronic and squid from Balt, which is quite the same thing with some differences. And we have new polymers coming not with tantalum but with iodine. It does not need agitation. This is a fill and EasyX, and I will come back on that. So the main risk and complications for sclerosing agents is pain. It can be painful when you inject sclerosing agents, and cardiopulmonary collapse, especially by endovascular approach, especially with alcohol. Of course, for cyanoacrylates, rates, this catheter entrapment, even if honestly I've never left any catheter in any patient. So if you are cautious when you embolize, there is no reason to happen. Even if it can be a little bit adherent. And for polymers, it can be painful because of DMSO injection. So depending on the location, you need general anesthesia, and you can get vasospasm, especially in arteries. And you need to be cautious, especially for superficial EVMs at the skin level to avoid any tattoo. So when you, general rules, when you use cyanoacrylates, you need to flush the dead space of the microcatheter with 5% dextrose solution. And this is very important, and very important to use a coaxial technique when you use cyanoacrylates or even onyx or squid or polymers, to use a coaxial technique, meaning a 4 or 5 French catheter and a microcatheter to make sure that you are safe. And with polymers, you need to flush the dead space with DMSO, as I said before. So it means that you need to know the dead space of the material and the microcatheter you use. And be careful again, because DMSO can be very painful. This is a solvent. For some indications, you need general anesthesia as compared to glue, which is less painful and even without any pain in most cases. So many potential indications in both arteries and veins. I will skip lymphatics for the use of lipidol, but for cyanoacrylates and copolymers, you can use them for EVMs, bleeding. I will come back on that. Hypervascular tumors, endolics, hypersplenism, BPH. I will show you some examples, and of course, portal vein embolization and varices in general. So what are the common theoretical advantages of all cyanoacrylates and copolymers? The first is that this is a permanent embolic agent, and the risk of recognition is exceptional as compared to some other embolic agents, especially mechanical agents like coils or even particles. You will see that I'm not a big fan of particles for very good reasons. And if we look at the literature, especially for this paper from our team about the use of different embolic agents for varicocele, for example, which is a very easy indication and embolization, we have shown that we got lower recurrence rates with glue than with other embolic agents, especially coils and sclerosing agents, and less radiation, because it's significantly faster to do this kind of embolization from the iliopectinate bone level. As you can see, even below, the goal is not to embolize the pompiniform plexus, but just above, up to the iliac bone level. You can really get glue in all branches in a very fast way. And it has been shown. There is a meta-analysis published 4 or 5 years ago by a team coming from UK about the use of different embolic agents for varicocele, and has been shown that the best in terms of risk of recurrences is glue, even if we have few papers as compared to other embolic agents with the use of glue. So meaning that it can be very interesting, but also with some other products like Venacil, which is a very viscous glue coming from Medtronic, which is made for treating great saphenous vein incompetence. The gold standard is a thermal ablation normally, but we are participating to a randomized study worldwide with this new technique, which is a non-thermal, non-tumescent, non-sclerosant therapy. which is just a very viscous glue. You don't need Lipiodol in that case. You just inject from this catheter. There is no need for any tumescence anesthesia, no risk of thermal injury. And it has been shown, if we look at the literature in terms of closure rates at 3 and 5 years, as you can see with the VECLOS study at 3 year, 94.4%. So even better than radiofrequency ablation, which is supposed to be the gold standard. And these results are maintained at 5 years and with no serious adverse events, and with a complete occlusion of the vessel, meaning that probably liquids in general, and in that case, especially glue, is even probably the best treatment for great saphenous vein incompetence, which is very interesting for this purpose. This is highly penetrable. Let me show this example of a female with bleeding uterine EVM post-abortion. You can see that there is an early venous return, and this is like an EVM. And you can see that the catheterism is quite complicated. We can see the nidus, and it's just impossible to reach the nidus with the tip of the microcatheter, but you can just play with the dilution with glue and Lipiodol. You see the injection on the right side of the slide with a 1:5, 1:4 ratio in that case, to make sure that the glue will be very distal. And for this kind of indication, I prefer glue than polymers. With polymers, you need to put the tip very far, because sometimes you can get reflux immediately, and you cannot reach the distal part, which is easier to reach with glue. And a second branch, as you can see here, the main one, giving the nidus. And there is no risk with polymers and with glue to pass through capillaries. I'm not talking about a direct fistula, but this kind of pseudo EVM, there is no risk of passage of the casts in the venous part as compared to particles. And you see the final control with the main uterine artery, which is maintained patent, and a very selective embolization and definitive embolization. I'm not a big fan of gel foam in that case, because there is a risk of recanization. So very interesting in terms of distal embolization, even if the tip of the microcatheter is far away from the bleeding point or the nidus. In terms of penetrability, if we talk about EasyX, which is a new product, we conducted a study with Vincent and Marc Saint-Paul and Vincent Vidal in France about the use for different indications. And you can see the difference. This is a iodine product, not tantalum, so meaning that it's less radiopaque, which is interesting in terms of artifacts. You see the difference for portal vein embolization here between Onyx here, very visible during the angiography, and EasyX, which is less visible, which is a drawback, but which is an advantage in terms of follow-up, especially CT follow-up. You can see the difference between artifacts with Onyx here because of tantalum, and EasyX, which is iodine with no artifacts at all, which can be very interesting, especially for follow-up of type, not in that case, but for follow-up of type 2 endolycs, especially, which can be very interesting. So here, the use of squid peri, which is like Onyx, but you have different versions now coming with less tantalum, LD version, light version, and coming with 34 version, 18 and 12. So one more version than Onyx. And the typical embolization of a type 2 endolytic, as you can see here, with a metallic needle in the nidus and a microcatheter inside, and then you inject under fluoroscopy to fill in completely with no artifacts, almost, as you can see here. So very interesting to choose the right version according to the territory you want to embolize and the potential follow-up you need. This is the occlusive effect does not depend on coagulation parameters of the patient, which is very interesting, especially for bleeding patients and massive and focal bleeding. Here an example of huge bleeding and huge extravasation from the left gastric artery. So it's probably the best indication. Every time you can sacrifice the branch which is bleeding, glue, even copolymers, but glue is the best option. I'm not saying that I mean, you can use whatever you want, everything works, but with 2 drops, 3 drops of glue, it's done. It's very fast, very efficient. There is no risk of recognition. You can sacrifice this branch without any issue. And at 3 o'clock in the morning in an unstable patient, this is probably the best option. And we have shown that it allows faster and better clinical outcomes as compared to other embolic agents in this retrospective comparative study published in European Radiology. But you can do the same thing with copolymers. We have an ongoing trial in France with different centers, including Vincent in Marseille, about the use of squid for bleeding patients in different indications. And you can see here an example of a small extravasation from a small branch of the superior mesenteric artery, and that we embolized with a cast of squid. It can be very fast also and very interesting. If we look at the literature, because most of people are thinking that glue and copolymers are very risky in terms of ischemia, which is not the case at all. This meta-analysis on the left side about the use of glue for GI bleeding. So the bowel, which is considered as the territory with the highest risk of ischemic complications, more than 400 patients, only 13 ischemic complications, and only 3 needed bowel resection, 3 among more than 400. So you cannot do less. Less is 0, so meaning that it's very safe, and even maybe safer with the use of copolymers. Few series with the use of onyx, but no major complications and no ischemic complications at all reported with the use of onyx for GI bleedings, meaning that it's very safe even for this purpose. This is a highly radiopaque. You can see a prophylactic embolization of angiomyolipoma in that case, very easy to do with glue, 2 main feeders, 1:5, 1:6 ratio. You will see the drops of glue going very distally, and then you will get stasis and reflux. And the endpoint is very clear in that case, and you can see the lipidal uptake at follow-up during CT. Some other examples, portal vein embolization. We know now that this is the best embolic agent, glue. This randomized study published last year comparing glue and particles plus COIS. Glue produced greater and faster liver growth. We know that. So high level of evidence for glue for portal vein embolization. And for liquids in general, I would say, this is a paper coming from our team with the use of onyx for portal vein embolization. Quite expensive, but very interesting for beginners. And you can see that the range of future liver remnant hypertrophy is very interesting in the range of what we can find in the literature with glue, meaning that liquids in general can be the best option for portal vein embolization in general. And you can start with copolymers and then switch in a second step with glue to become more comfortable with the use of liquids in general. You can reach any distal targets with small microcatheters. Let me show you this example of a bleeding from the inferior mesenteric artery. You see a sigmoid branch, colonic bleeding. Here, 2.0 French microcatheter. It was impossible to go behind. So it means that, and if you don't do sandwich embolization, in that case, you can get recurrence. You can see on the final control that so you need to embolize. This is in a blocked manner. Here you can, with glue, make a cast going very slowly behind the bleeding point and make this sandwich embolization, even if the tip of the micro is far away from the bleeding point. And that's what we did in that case with only 2 vasorecta embolized. And you can see that it's absolutely mandatory to do this. If you put just COIS here, you can get recurrence. Another example of abdominal pain for 3 days seen in consultation. After the day after, you can see the hematoma, mesenteric hematoma. You can see there is an aneurysm of the pancreatic duodenal arcade. In that case, with a celiac trunk occlusion, it was impossible to go behind. You can see the aneurysm here. And it was impossible to go behind because of the loops here. So we decided to embolize from that point with a balloon to occlude and to slow down the flow with copolymers, something very viscous, to go behind and make a sandwich embolization. As you can see here, that's what we did. If you don't do sandwich embolization, you will get recurrence immediately. And then that's what we did, meaning that you can use copolymers in a blocked manner with a balloon, an occlusive balloon microcatheter, which can be very interesting. And last but not least, it's very easy to deliver, allows for fast procedure. Here, a non-germinal lipoma, again, with a lot of aneurysms, the main feeder. And you can see that if you use particles, you need to use additional coils here in each artery, because you will not occlude the aneurysms with particles. Here you can do both with the same embolic agent, distal and proximal embolization, and it takes 15 seconds to do this instead of 1 hour with particles. So very interesting. And in terms of perspectives, maybe the use of glue for prostatic artery embolization. We published the first paper with 50 patients. It was a safety study with very nice results at 3 months in terms of clinical outcomes, as in the range of what we can find in the literature with particles. And there is a retrospective study comparing glue and particles in the literature, and in favor of glue in terms of radiation, and because it's faster in terms of injection. It takes 10 seconds on each side instead of 10 or 15 minutes. So very interesting. Let me show you this example here. That's what we did with a 1:8 ratio with glue. You can see what you are doing compared to particles. It's very fast. You do both distal and proximal embolization here on both sides. You can see you can have lipidal uptake on a CT scan, which is very interesting. Let me show this movie in a free flow injection here. This branch giving the left lobe of the prostatic artery, and you can see the selective embolization, and you will see the glue going very fast in the distal gland, and you will get a reflux, and you see what you are doing, and you have reflux, and when you have your endpoint, then you just stop to inject. And on the right side, in a blocked flow manner, you can see that the microcatheter is blocked here, and then you can use the plug and push technique like for copolymers, wait a little bit even with glue, and then being able to re-inject in the distal part and to get deeper penetration in the gland. That's what we did, and remove the microcatheter after 1-2 minutes without any issue, and it can be very interesting. So it's probably, we need data still, but very interesting to use for this purpose, because it's as effective on the short term. It's faster, you get less radiation in a very challenging intervention sometimes with lower radiation dose. The endpoint is very clear because you see it as compared to particles, and because it's fast, you don't have any you don't reopen collaterals. There is the LUMI study which is on the way to be published in UK with the use of radiopaque beads for prostatic artery embolization, and they showed that you have particles everywhere in the pelvis when you embolize with particles. Probably in most cases it's hopefully it's asymptomatic, but it's very interesting, probably because you reopen collaterals that you don't see, which cannot happen with glue, I would say. And probably we have less recurrence on the long term. We are working on that because you embolize both distal and proximal part of the artery. So just some very nice indications I wanted to show you. Liquids in general are very useful, a huge interest for peripheral applications. It can be the best choice, especially in bleeding patients, when you can, every time you can sacrifice the branch which is bleeding. Whatever the coagulation parameters of the patient, very important, very interesting. You can reach any anatomical site with no more ischemic complications, even for the bowel. Of course, we need more and more evidence. A lot of new products are coming on the market soon, and with different features and different advantages in terms of viscosity, visibility, and so on. And it can be very interesting to use them for many indications. Thank you very much for your attention.